our experience in patient-specific engineering approaches in congenital heart disease. Firstly, I want to thank to Professor Dr. Ender Ödemiş. He is founder of our research team. Actually, our story was started 5 years ago. After COVID pandemic, Professor Dr. Ender Ödemiş has started his PhD degree in biomedical engineering, and this situation has changed our approach to congenital heart disease. Previous year, he finished the PhD program, and he has a PhD degree in biomedical engineering. We have a great team. We are working with biomedical engineers, 3D specialists, and so we have a chance to evaluate our patients in that approach. Let's start. Congenital heart disease are not a single disease. Maybe most of time we can think about a diagnosis, but every patient has a specific in different conditions. But many of our current therapeutic tools are standardized, and biomedical engineering approach can help us to solve these problems. As you know, we are using some advanced imaging techniques, but the different part is we can use some computational modeling techniques like CFD and others. And also, for some selected patients, we can use in vitro simulation techniques, and all these techniques can help us to differentiate the pathology and the treatment options. Today, firstly, I wrote there in vivo simulations, but actually in vivo imaging techniques can be a better explanation. Especially for 3D echoes, strain echoes, 4D flow MRI, and other techniques. These help us to understand the physiology inside the patient. Then we will talk about some in silico simulation techniques like CFD, finite element modeling, and digital twin modeling. And at the end of the presentation, I will give some examples from our in vitro simulation tests. We can start from the heart. Traditionally, we are talking about valves, pressures, but nowadays we can talk about energy loss, flows, energy loss, hotspots, wall shear stress. I think our approach is differently changed to a totally different area. Now I will talk about some of our patients. An adolescent case of aorta. She was 11 years old patient. As you see, RPA is arising from the ascending aorta. Traditionally, we have performed a CAT, and in this condition, maybe the patient looks unoperable. Dr. Alpay Çeliker has thought about this patient, what can we do? Then we decide to perform an inhaled inoperose test with 2D fast contrast MRI for pulmonary vascular reversibility. At the end of this, before the test, we record the 2D fast contrast cardiac MRI for the RPA. We gave iloprost to the patient, and we performed the test again. And we show that pre and post, the pulmonary flow volume increased 42%. it means that maybe still this patient has a chance to operation. Then also we planned a biopsy, and the biopsy showed us the patient's degree of the pathology was stage 2 to 3. So we performed a successful operation, and this is the third year after this operation. The patient has no symptom. Everything is good. And sometimes we can use 4D flow MRI for spatial complexity. Traditionally, actually, we can understand the mechanism. For example, this is an adult scimitar syndrome. But 4D flow MRI can show us there was a narrowing in the lower diaphragm part. This is actually, this is for us and for pediatric cardiovascular surgeon, and also we can use this data for education. Now I will talk about some in silico segmentation. First of all, we are performing the segmentation techniques dot by dot. It takes so much time, but mostly we are using Inobitech, but there are some open source tools like 3D Slicer or ITKSnap. You can use them, they are free. Before our group, it takes hours. For complex cases, maybe more. But now we can segment a patient's data in minutes. It can show us everything more clearly, more instructive. Also, I want to show this patient. This patient has a large VSD and pulmonary atresia. She admitted to our hospital with severe cyanosis. In CT angiography, we noticed that still she has a chance to operation because distal segments of the MAPCAS has the significant narrowing. As you see, then we operate this patient successfully. In the second year after the operation, everything is normal. There is no pulmonary hypertension. Saturation level increased to 95 from the 60-65. This is a very complex case of Dr. Kalangos. She was a 4-year-old female. She is a 4-year-old patient. She has crisscross heart. This is after operation. I think CT imaging to understand is very hard. Also, after segmentation, it's hard, but we can see that in that pathology, the upper part is right ventricle, lower part is left ventricle, and there is an angulation problem of arcus aorta due to this pathology. After the operation, Dr. Kalangos enlarged the arcus aorta, and the patient problem about pulmonary stenosis due to the angulation is solved. Another patient, she was a Fontan failure patient actually. She has admitted to our hospital with severe abdominal pain and distension. She has a very long story, but we performed a catheter angiography. At the beginning, actually the pressures look normal, but as you see, there is a flow problem in that area, but the pressures are looking normal. We performed a 4D flow MRI. We saw that actually there is a loss of energy in inferior vena cava in fontan area, the lower part, and also there's another problem is the proximal part of the left pulmonary artery. Then we performed, a balloon dilatation of the fontan tube connection, and also we have used another stent for left pulmonary artery, and then the patient's problems were solved. Then we continue to learn something about biomedical engineering and also for the flow MRI. Then we started to think about that, yes, it was effective, but for the flow MRI is a reality or an illusion. Because spatial resolution of 4D flow MRI is very low. So it creates some blanks in the patient's data. Sometimes it is like an hallucination with AI. Maybe we can think that. But for our patients, we showed that it was true for our patient, and we showed it with computational fluid dynamics, because after we planned pre-dilatation and after dilatation, the results are better. But we continue to work about this issue. The comparative hemodynamic analysis of fontan patients using CFD and 4D flow MRI. And it showed us, yes, we can use some patients, we can use 4D flow MRI some patients, but if we have a suspicion, we have to check it with computational fluid dynamics or other in silico models. I think in future, with better 4D flow MRI data, probably we have a chance to use it more and more in clinics. But for now, I think we need time. I will show you our work with in vitro stimulations. Actually, normally, we are using a device or valve to all patients, but it is true or not. We want to test it for the same size for the different RVOT anatomies, and for these we planned at the same measurement, like 30 millimeter, and we tested with 28 and 32 millimeters with different RVOT types for 1, 2, 3, 4, and 5. We use Vivitro duplicator system. We performed 195 experiments. We measured the gradients and regurgitation flow rates in LPA and RPA. And we showed that, yes, for RVOT type 1 and type 2, the same measurement can be used, but especially for RVOT type 3 and 5, there is a risk for stenosis and regurgitation. So your treatment can be changed to RVOT types. Another study, and we have learned so much thing from our in vitro, in silico models, then in vitro studies. Then we designed an ex vivo mitral valve model, because it was a thesis of our colleague from another university, and he used pulse duplicator system for different techniques for mitral valve repair. And it was published of using a different ex vivo mitral valve surgical repair testing model, and it is published. And we checked, she used different techniques to repair mitral valve, and then we checked it with echo. And this part, it will be published, her thesis in future. And the last part, I want to give some information from some other centers as innovations. This is the last edition of NADA's Pediatric Cardiology. In the innovation part, there is a chapter for the localization of the conduction tissues during cardiac surgery. Especially, it is very hard for all of us because maybe co-triangle was found 150 years ago, but still we have problems about that. There is a risk for generally 1% of patients with AV heart block. This is a study from Boston Children's Hospital. Actually, they have a portable electrophysiological for EPS device, and they are using an HD grid mapping catheter. It takes only 6 to 8 minutes to show exact anatomy of the AV node, and they showed that the rate of complete AV heart block decreased to 2 to 3%, especially for complex cardiac disease. This is not a routine, but I believe that especially it can be used for complex pathologies in future, I hope. This is my last slide. Actually, we are learning so much things from biomedical engineers. I believe the Pediatric Heart Center, Pediatric Heart Team, and in future, I think biomedical engineers should be a part of this team. We will learn more with better CT or MRI data. We will simulate them. In some patients, we will create some mock-up models, and we will use this for treatment, and probably we will use these techniques for the monitoring. In future, probably we will use more and more these techniques, and we can prepare. We have improvement results, improved and better results with our patients. Once more, I want to take this great team to Ender Ödemiş Hoca and to my other colleagues. Thank you very much for this opportunity.
Congratulations, Dr. Kizilkaya. Very useful knowledge. And for the imaging, the accurate diagnosis, the interventional procedures, the surgery. Comments or questions at the end? You went, okay. Just a question. Okay, so, now.
Congratulations on an excellent talk, actually. And I'm surprised that you are involved in so many of these things. I think the segmentation and 3D models are very important nowadays for planning complex procedures like Nikaidos. We started doing 3D modeling, and we just started. I like to have them for Nikaidos, for instance. And but this is far ahead. This is amazing. Thank you for this.
I think so.
Thank you. You were impressive, your work, but I would like to know what is the percentage of congenital heart diseases in Turkey?
Sorry.
Percentage. How many babies are born with congenital heart disease?
1%.
1%?
Yeah.
Per 80 million?
Yeah.
Okay. Thank you.
Thank you so much.
The next speaker is Professor Vlahovic.
Okay, Mr. Vlahos, the Professor Vlahos.